It's a real pleasure to be here. In the job that I do, I'm very fortunate to be doing the job that I do, but a lot of my time is spent in meetings, committee rooms, and in offices in central London. So it's been extremely humbling and helpful for me to be here and hear about the project. I've looked at a lot of the details around the project, and I'm not going to necessarily put my hands up and do lots of mea culpa, but it is really singing a lot to me about some of the things that we are missing, not just in mental health policy, but in public health policy. And I take a lot of what's been said this morning very seriously. So the project, I hope, will come up with not just the issues and present it in the way they've done, but with you also co-produce some really important ideas. And we've got a little bit of a reflection of, I think, the distance we have to travel to move our policies into relieving social distress, austerity, and poverty that improve what I call good mental health. So let me thank the organizers. I've loved all the local examples. I'm going to soak up as much as I can here. It's great to see a lot of research and other policy colleagues here. It's great to see Martin White from Public Health England Southwest involved in this project. So let me reiterate what Heather has said and talk about the questions we'd really like to explore with you. How do we increase the capabilities of people and communities to do this in the absence of what I would call decent and fit-for-purpose national policies? How do we emerge the emerging and emergent work that's happening locally and get that far more into the agenda on public health prevention and promotion? And how do we truly integrate? Because at the moment, when I look at the definitions of mental health and well-being, I find our policy landscape in England to be wanting. I had a long time of working in Scotland. I miss Scotland drastically, so it was really, really great to hear some of the things that are still going on in Scotland. And I think one thing that Scotland does really well with policy is it may have too many policies, and we always talked about the policy virility of Scotland's new legislation as if that was a good thing. However, what it does do is the policy narrative authorizes behaviors to move in the direction of combating social injustices. And what we seem to be missing in our individualized policies is any overarching narrative. We may say the burning social injustices is the overarching narrative, but I would like to see more of that writ large through policies. And when I look at the NHS long-term plan and its definition of prevention and communities and people, I don't find anything that gives me hope beyond the really important element of increasing resources in mental illness treatment services. Sorry, I'm kind of giving away the whole program, aren't I? Okay, so what Public Health England does have an approach to mental health. We are your public health agency. We are, like many others, the King's Fund have said it better than us, the Health Foundation have said it better than us, but only 10 and a maximum of 20% of improvement in people's life, mental health and well-being will be increased by high-quality, effective, modern, evidence-based services. So you have to assume that our services are modern, evidence-based, targeted at those that most need them, and then you're getting 10 to 20% improvements in health, leaving 80% of improvements of health out with the health system. So why is our consistent reaction to mental health policy solely focused on more money for mental illness treatment services at the expense of continued investment in public health? We did a good thing by putting public health into local authorities. They have much more of the levers on the social determinants of health and well-being. Yet, we have seen in it nearly £700 million worth of cuts, £85 million worth of cuts next year, and 4% cuts in the public health budgets to come. If our policies are to be integrated, our investment in mental health policies to relieve social distress and improve mental health are out of kilter. So if I look at the definition of policy, it's a set of ideas or a plan on what to do in a particular situation or on particular issues that have been agreed officially by a group of people, business, government, or political party. So what I'm going to try and do is give you some of the analysis that others have made. And Lynn Friedley published this in 2008, and we supported her when I worked for the Scottish Government to produce this document for the World Health Organization. And this basically says it all, and we should mark the improvements in mental health policy against this lens. We know the powers of community and community-based approaches, and in Public Health England we're very pleased that we have an active programme on communities headed up by Professor Jane South and Jude Stansfield from Leeds Beckett University, and we've produced an awful lot of evidence. We also have a community assets-based approach across our organisation. We have our centres and our national programmes all working to introduce community-based approaches to overall health and well-being. The other aspect of mental health policy is we seem to have overall health and well-being policy, and then we have mental health policy. We have housing policy, then we have housing and mental health policy. We have employment policy, and then we have mental health and employment policy. We are othered in the policy world, and that does us no favors. But aren't we so grateful when there is an attention in the policy world or in the public world? So, mental health as awareness is increasing. There are more public policy statements on mental health than ever before, and we know that investment in mental health services is good. That's good. I, like Paul, am optimistic, despite my Northern Scottish Presbyterian, slightly Calvinistic upbringing. I do smile. This is about as jolly as it gets. But I do think that some of the things that we really need to be concentrating and looking at are the distance that we've come between some of the rhetoric and some of the reality of what we're able to implement. And I'm happy dealing with rhetoric, but I'm not happy about leaving rhetoric standing and, as a public health agency, not advocating on yours and community's behalf for a greater focus on addressing the social determinants of health and well-being that include the social determinants of mental health and well-being. They're no different, so why do we need different policies? Let me skip that slide in the interest of time. This is to show you that Public Health England is actually doing something on building connected and empowered communities and doing something on psychosocial determinants. We produced an awful lot of evidence and documentation last year on the move to prevention, and I really want to extol some of the virtues of that because that's aimed at local systems. So when we look at approaches that are needed, they need to be evidence-based. We need to use the evidence to inform what we do in policy, but we mustn't go from evidence-based to evidence-informed to evidence-ignored. And I am just worried that at the moment we have a slight default away from addressing the wider determinants and more focus on securing further investment in health services as a way to meet social and other community-based pressures, which would lead us on to using biomedical models and the tools we have at our disposal, whether that's talking therapies or pills, to respond to and pathologize everyday life and the social conditions we find ourselves in. So we need evidence-based, we need evidence-informed, we need the authorization. And it was earlier today that we heard that if you actually do, and it was from Tony, if you actually do use the right language, for example, in the Police Act in Scotland, using the right language authorizes people. I remember in Scotland when we were doing the Mental Health Act in Scotland, we said, if we remove your freedoms for a short, brief period of time for your safety and security and that of others, we get into a reciprocal arrangement with you whereby we promise to give you a full assessment of your social, economic, housing and employment needs. That is true authorization to address on an individual scale the wider social determinants. That part of the policy was never properly enacted, but it's a very, very good piece of legislation. And I searched long and hard in the Mental Health Act review of England to find any such bold policy statements of reciprocity, and still haven't been able to find them. So we need to use policy as an authorizing vehicle, and we need to use policy to devolve decision-making, control and power to local areas, communities and families, which a lot of areas around this country, as you've heard from this conference, are doing exceptionally well. We do require a mental health impact assessment of all policies, but as part of overall health impact, we do need joined up and overarching policies, and the key aspects of what we need to take forward in mental health policy, which will be true levers alongside these, are asset-based needs assessments in local areas, community-centred and empowered approaches, oodles of which we've heard about today, collaboration, integration, and not transactional, but transformative, and built on the stories and real-life stories of people in communities who we don't hear enough about because they are more distant and further from some of the privileges that other communities in England enjoy at the moment. Thank you.